Welcome to Section 5 of Neuropathology. In this section, we'll be discussing dementia and degenerative disorders. Let's get started. Here's our overview slide. Let's begin by discussing Alzheimer's disease. This is the most common cause of dementia and is most commonly seen in the elderly. Patients with Down syndrome have an increased risk, and this is thought to be a result of the APP gene, which is on chromosome 21. And recall from genetics that Down syndrome is due to trisomy 21. Although the majority of Alzheimer's cases are sporadic, some are familial. The familial form is associated with mutations in presenilin 1 and presenilin 2. The ApoE4 gene has shown to decrease the risk of developing the disease, and the ApoE2 gene has shown to increase the risk of developing the disease. Alzheimer's disease causes degeneration and atrophy of the cortex. The cerebral atrophy and degeneration leads to narrowing of sulci and widening of gyri. A dysfunction in amyloid precursor protein cleavage results in the overproduction of beta amyloid. This causes beta amyloid to build up in plaques in the brain. Another feature is neurofibrillary tangles. These are caused by the accumulation of hyperphosphorylated tau protein. The final feature is the alteration of the nucleus basalis of Maynard. This nucleus houses cholinergic neurons, such as acetylcholine, and a decline in acetylcholine is thought to be partly responsible for the cognitive decline seen in Alzheimer's disease. Here is an image depicting where the nucleus basalis of Maynard is located anatomically, so right here. Here are two images. The one on the left is a normal brain, and the one on the right is a brain of a patient with Alzheimer's disease. Notice the narrowing of the sulci, for example right here, and widening of the gyri, for example right here. The hippocampus is especially susceptible to damage in patients with Alzheimer's disease. The hippocampus may experience shrinkage, as shown here, and there may be diffuse cerebral atrophy, which can lead to enlargement of the ventricles, as shown here. This is an H&E stain of a brain biopsy in a patient with Alzheimer's disease. Here you can see beta amyloid plaques. A dysfunction in amyloid precursor protein cleavage results in the overproduction of beta amyloid, and this causes beta amyloid to build up in plaques in the brain, as we discussed previously. Here is another H&E stain of a brain biopsy in a patient with Alzheimer's disease. Here you can see a neurofibrillary tangle. Again, these are caused by the accumulation of hyperphosphorylated tau protein. All right, now let's discuss some clinical features of Alzheimer's disease. The diagnosis is presumed clinically. A confirmatory diagnosis can only be made post-mortem when examining the tissue histologically. Patients will present with a slow onset progressive memory loss. There may also be behavioral and psychological impairments, such as apathy and social isolation. Finally, patients may progressively develop visuospatial and language defects. All right, now that we've covered some information, let's review with a quick question. A 72-year-old male with a past medical history of hypertension and type 2 diabetes mellitus is brought to the physician by his wife due to concerns about his memory. The patient admits he has had trouble with his short-term memory over the past few years and thinks it is worsening. The patient denies any hallucinations or bradykinesia. Which histological features are seen in this patient's condition? All right, this patient is suffering from Alzheimer's disease. This most commonly affects the elderly, and this man is 72 years old and is having issues with his memory. This has occurred gradually over the past few years and is worsening. These features are suggestive of Alzheimer's disease. Recall that in this condition, beta amyloid plaques are seen histologically. This occurs because dysfunction in amyloid precursor protein cleavage results in the overproduction of beta amyloid. Another histological finding is neurofibrillary tangles. These are caused by the accumulation of hyperphosphorylated tau protein. All right, now let's move on to discuss vascular dementia. Vascular dementia is caused by numerous arterial infarcts over time. Patients will present with a stepwise decline in their cognition, and this is the second most common cause of dementia. All right, now let's discuss Pick disease. This is also known as frontotemporal dementia. It's characterized by neurodegeneration of the frontal and temporal regions. Patients classically present with behavioral and personality changes, which can manifest as behavioral disinhibition, compulsive behavior, or oral fixation. Pick bodies are seen histologically, which are round aggregates of hyperphosphorylated tau protein. Here's an H&E stain of a brain biopsy in a patient with Pick disease. You can see the Pick bodies, for example, right here. And again, these are caused by the accumulation of hyperphosphorylated tau protein. Next, let's discuss Huntington disease. This disorder is an autosomal dominant condition. It's caused by CAG trinucleotide repeat expansion in the Huntington gene on chromosome 4. It's also important to remember that this disease demonstrates genetic anticipation. This causes the severity to increase and age of onset to decrease in successive generations. All right, now let's discuss the pathophysiology. The disease leads to the degeneration of the caudate nucleus and putamen in the basal ganglia. This causes an increase in dopamine and a decrease in GABA and acetylcholine. Elevated dopamine levels activate the nigrostriatal pathway, which results in choreiform movements. These elevated levels also activate the mesolimbic pathway, which results in psychotic symptoms. Here's an image of the brain anatomy. Here we can see the caudate nucleus and the putamen. So Huntington disease leads to the degeneration of the caudate nucleus and putamen in the basal ganglia. This causes an increase in dopamine and a decrease in GABA and acetylcholine. Patients typically present with choreiform movements, which is due to excess dopamine. These are involuntary, jerky, and writhing movements of all of the limbs. They'll also have dementia and depression, and eventually the disease leads to death. However, patients with this condition commonly commit suicide. All right, now let's discuss Parkinson's disease. The etiology is unknown. However, in some rare instances, it has been associated with a toxic chemical found in illicit drugs known as MPTP. This is toxic to the substantia nigra. Parkinson's disease is the result of neurodegeneration of dopaminergic neurons in the substantia nigra pars compacta, which is in the basal ganglia. This disrupts the nigrostriatal pathway, which is responsible for movement. Eosinophilic inclusion bodies will be seen histologically, and these are known as Lewy bodies and are composed of alpha-synuclein. Here are two brain images from our physiology chapter. On the left is a cross-section, and on the right is a frontal section. We can see the substantia nigra right here and right here. This area is responsible for movement, so disruption of this region is what causes the classic movement dysfunctions seen in Parkinson's disease. We discuss the physiology of these pathways in much more detail in our neurophysiology section, so be sure to check that out if you need a refresher. Here's an H&E stain of a brain biopsy of the substantia nigra pars compacta in a patient with Parkinson's disease. We can see a Lewy body, for example, right here. Again, these are eosinophilic inclusion bodies composed of alpha-synuclein. All right, now let's discuss some of the clinical features of Parkinson's disease. The constellation of movement symptoms are due to a loss of dopaminergic neurons in the substantia nigra pars compacta. This causes patients to present with a pill-rolling tremor, which is a tremor of the hand at rest. Patients may also have cogwheel rigidity, which is a form of muscle rigidity, akinesia or bradykinesia, which is the loss of movement or slow movement, respectively, postural instability and a shuffling gait, and dementia, which is a sign of advanced Parkinson's disease. All right, now let's discuss spongiform encephalopathy. This is a disorder related to prion proteins. The most common form is Creutzfeldt-Jakob disease, or CJD. CJD is most commonly sporadic. However, it can be caused by exposure to prion-infected cattle or human tissue. And finally, familial fetal insomnia is an inherited form of spongiform encephalopathy. Under normal conditions, prion proteins are found in the CNS in the alphical helical formation. Patients with spongiform encephalopathy will have their prion proteins converted to a beta-pleated formation. This beta-pleated configuration is resistant to CNS proteases, and this causes an accumulation of beta-pleated prion proteins, which causes cytoplasmic vacuoles and neuronal death. This is an H&E stain of a brain biopsy in a patient with spongiform encephalopathy. You can see cytoplasmic vacuoles, for example, right here. Again, these are caused by an accumulation of beta-pleated prion proteins, which causes neuronal death. Patients with this condition present with rapidly progressive dementia that occurs over the course of weeks or months. They'll also have myoclonus, and death typically occurs within 1 year. Periodic sharp waves may be seen on EEG, and the 14-3 protein may be seen in the CSF. This is a protein that's released into the CSF when brain cells die. All right, now let's review with another quick question. A 69-year-old female with no past medical history presents to the physician due to concerns of uncontrollable hand movement. The patient appears to have rigid movements on physical exam, and a resting tremor of the hand is noted. What is the anatomical location of this patient's brain abnormality that is responsible for her current symptoms? All right, this patient is suffering from Parkinson's disease. She has a pill-rolling tremor and cogwheel rigidity. And as we just learned, Parkinson's disease is due to loss of dopaminergic neurons in the substantia nigra pars compacta. So the answer to the question is the substantia nigra pars compacta. All right, let's finish up by discussing normal pressure hydrocephalus. The cause of this disorder is idiopathic, but it's most commonly seen in the elderly. The pathophysiology is related to an increase in cerebrospinal fluid. This results in dilation of the ventricles, which stretches the corona radiata. This leads to the classic triad of symptoms known as wet, wacky, and wobbly. Wet refers to urinary incontinence, wacky refers to cognitive impairment, and wobbly refers to gait impairment. A patient may experience symptom relief when a lumbar puncture is performed due to the draining of excess CSF. Finally, treatment for this disorder is a ventriculoperitoneal shunt. This diverts fluid away from the ventricles and restores normal flow and absorption of the CSF. Here's an MRI of a brain in a patient with normal pressure hydrocephalus. Notice that the ventricles are very dilated. This causes stretching of the corona radiata, which leads to the triad of symptoms known as wet, wacky, and wobbly. All right, now that we've covered the information, let's review with a final question. A 45-year-old female with no past medical history presents to the physician for her annual physical examination. The patient's current temperature is 36.8 degrees Celsius, blood pressure is 128 over 80 millimeters of mercury, heart rate is 69 beats per minute, and the respiratory rate is 13 breaths per minute. The patient states she has felt depressed over the last year. Further questioning reveals her father committed suicide in his early 50s. On physical examination, the patient is noted to have jerky, writhing, uncontrollable movements in her arms and legs. Which of the following is most likely seen in this patient's condition? A. Elevated levels of dopamine. B. Loss of dopaminergic neurons. C. Accumulation of cytoplasmic vacuoles. Or D. Narrowing of sulci and widening of gyri. All right, the important thing to recognize here is that this patient is experiencing depression and choreiform movements. This is highly suggestive of Huntington disease. The next step is to identify what is the cause of this, and recall that this is caused by degeneration of the caudate nucleus and putamen in the basal ganglia, which leads to elevated levels of dopamine and decreased levels of GABA and acetylcholine. Another clue to her disorder is that her father committed suicide at an early age. Huntington disease is an autosomal dominant disorder, and suicide is a common cause of death. Therefore, answer choice A is correct. From this slide, recall that Huntington disease can lead to elevated levels of dopamine. B is incorrect because loss of dopaminergic neurons refers to Parkinson's disease. This results in a constellation of symptoms including a pill-rolling tremor, cogwheel rigidity, and dementia. C is incorrect because an accumulation of cytoplasmic vacuoles are seen in spongiform encephalopathy. This leads to neurodegeneration and rapidly progressive dementia, and death usually occurs within 1 year. D is incorrect because narrowing of sulci and widening of gyri is associated with Alzheimer's disease. So again, the correct answer is A, elevated levels of dopamine. And that concludes this section.